So the epidemiology-wise, in India we have previous studies like taking the cutoff of 5.5. The 7 city studies found that the prevalence is somewhere around 7 to 9. Kolkata it was 11, so it was around 7 to 9. Marwa et al, they took a cutoff of 4.2, and in our study we took a cutoff of 4.2. There we found that the prevalence is more. In our case, it was almost 1/4 of the population was having high PSA, so you can consider them as subclinical hypothyroidism. Whether you treat them or not, that is a different question, but epidemiologically they have that problem. And Marwa et al also find 1 out of 5 Indian population they have subclinical hypothyroidism. Any clinical feature, do the clinical features help? It is very interesting again. There are many symptoms of subclinical hypothyroidism which are present in normal population. So you cannot actually, based on clinical features or any clinical scoring system, you cannot actually differentiate whether the patient is having subclinical hypothyroidism or not, because there is a huge overlap between overt hypothyroidism, subclinical hypothyroidism, and euthyroid population. So clinical features are not that much helpful. They are helpful only secondarily, not primarily. What are the controversies regarding the treatment of subclinical hypothyroidism? Whether to treat them, because we said it's a subclinical disease. So any subclinical disease can only be treated if there is a future morbidity associated with that. So should we treat them or not? So what are the arguments in favor of treatment? So one argument would be you can prevent overt hypothyroidism, or you can actually have a potential impact if you bring down the THS below 10. And especially in conditions like this, like mood disorders and reproductive asthenia, infertility, pregnancy, etc. So there are certain conditions where probably we are proactive in treatment, but mostly not treating the patient may not cause any huge harm to the patient, but you have to be on alert, because the argument against treatment is a cost, danger of over-treatment, and in many patients there will be reversal to normal, and data regarding improvement in various clinical conditions, mood disorders, etc. are very, very vague. They are not very solid. But still, I will provide you some clinical trial data so that you can derive an opinion whether to treat or not. So, what about the progress of mild thyroid failure or subclinical hypothyroidism? So, initially you can see the initial TSS keeps on rising, but when the TSS is rising above normal, your T4, T3 could still be normal. Then the T4 starts falling and T3 falls the last thing. It's the last thing to happen. So this is how a normal hypothyroid disorder will progress. And this will take years for a whole population of patients having subclinical hypothyroid to have overt hypothyroidism. Many of them will not become, because they will have a reversal. And there are some interesting data regarding reversal. You know, if you do not have antibody positivity, there is a chance that a huge number of patients could actually reverse from subclinical hypothyroidism that is less than 10 or more than 4.5 or 5 to normalcy. So that's why their argument is also against treating all of them. But if you are antibody positive, there is a more and more chance of progressing into overt disorder, and that's how it is actually. Every year, there will be the progression of 5% per year if there is antibody positivity. Okay, and if there is antibody negativity also, there will be a chance of 2 to 2.5% progress. So antibody itself again doesn't tell you in a very convincing term that yes, if there is antibody positivity, I have got hold of a person who will definitely become hypothyroid and must treat it. But that is only one thing which helps you to decide on the treatment. So antibody testing is important in subclinical hypothyroidism. So, what is the recommendation from American Thyroid Association is that it should be considered. They are not saying that it must be considered. And if antithyroid antibodies are positive, hypothyroidism occurs at 4.3% per year versus 2.6% per year when antithyroid antibodies are negative. So, the presence of positive thyroid antibody may or may not influence the decision to treat. Again, there is a controversy here. We have not yet arrived at a conclusive decision regarding antibody testing and the decision thereof. What about subclinical hypothyroidism and cardiovascular outcome? So there has been various studies which have shown that if there is subclinical hypothyroidism, especially around the range of 7, 8, 9 years, to be increased cardiac issues. So I'll try to show you this beautiful diagram where If you are euthyroid and if you have subclinical hypothyroidism in the range of less than 4, the hazard ratio is not significant.